But I think,
I mean, it looks fairly, it looks okay. So, I mean, the general rule of thumb is, the most important thing is the height that you're sleeping at.
Right.
And so the height that you're sleeping at, you should ascend at no more really than 300 metres per day, and then every 3 days or every 1,000 metres have a rest day, which looks like it's sort of more or less how they're built into it.
But that's above 5'8"?
No, that's anything that's classed as high altitude. So that's from your base that you're starting at. So you're starting the walk at 2,700. Right. So people don't get altitude sickness below about 2,500. So below that, you can get sort of height-related changes, but you won't get altitude sickness at that height. So aeroplane cabins, for example, are pressurised to below 2,400 to stop people getting unwell, but not so they have to over-pressurise it. So anything over 2,500 metres, you can start developing symptoms, and you develop symptoms based on the absolute height that you're at, but also the rate that you're ascending. So that's why it's useful to keep the rate of ascent to less than 300 metres per day.
So we're down 4,000 metres increase, aren't we?
In total?
Yeah.
Yeah.
Which must be 13 days plus a few rest days.
Yeah.
Okay, so that just about pans out, doesn't it?
Yeah, we're just going over
Just
that.
about.
Yeah.
But not by much.
Yeah, not by much.
Not by much in this days.
Yeah.
Okay.
I would be going up and down all day.
Right.
Yeah.
Going down counts pluses.
And so, like, the acclimatisation process is important. So it takes 2 or 3 days for your body to sort of to make a few changes to help you adapt to altitude. You adapt more the longer you stay there, but the initial adaptation phase changes how your body's hemoglobin binds to oxygen, and that takes a few days to happen. So I think you've got a plan to stay at altitude for a little while before you start ascending. But it does look like it's sort of quite soon you get into it and start going up. So you drive to 1,300, and then day 4 already you're starting to walk up 1,900, but that's still sort of below sort of the level you'll be getting symptoms at. But then it's progressively higher and higher from then. So they don't really give you time to acclimatise at one specific height. You've got a series of ascents for the first sort of 6 days or so. Which, I mean, it's at fairly low altitude, so you should be okay, but you'll need to be looking out for symptoms. And so normal changes that happen as you go to altitude, so because the oxygen concentration in the air is less, you will find it harder to breathe. So those of you that have been to altitude before, I'm sure you remember it from last time, but your exercise tolerance is vastly reduced. You can't walk as far or go as fast or walk for as long as you could do at sea level, for the simple reason that your body's not able to absorb as much oxygen per minute. So that it's completely normal, but you need to allow for that and be sort of less ambitious. So becoming short of breath is normal. Your heart rate going up a little bit, that's completely normal. Swelling of your hands and feet, so just like happens in an aeroplane, so a little bit of fluid retention in the hands and feet is completely normal and isn't a marker for developing altitude sickness, isn't a marker for any complication. It's just a normal thing that happens and changes. The other thing is passing urine, so you're going to wee a lot more than usual. And it's to do with the sort of the acidity of the urine, the acidity of the blood, how that changes. It just stimulates the kidneys to produce more urine. So that's, again, it's a completely normal thing that happens and isn't anything to worry about. There's a few other normal things that happen which can be slightly problematic. So the first thing is sleeping. at altitude, people, because you're getting less oxygen while you're breathing, while you're asleep, you tend to sleep lighter and you tend to wake up more during the night. Sometimes people experience short periods of not breathing, so 10 or 12 seconds or so of stopping breathing, and that happens more at night time. It's to do with your body's sensors and whether they're sensing carbon dioxide or oxygen. But because of altitude, you tend to be stimulated to breathe more, and as you breathe more, your carbon dioxide level decreases in the blood, and then the centres that detect that think, oh, there's no carbon dioxide, we don't need to breathe, and so you stop breathing for a little while. And that can make you, especially when you're asleep, so you wake up and feel breathless and feel sort of a pressure on the chest and feel like you're suffocating. And it's not pleasant, but it's not serious either. And it will go away as you begin to acclimatise. And again, it's not a marker for developing altitude sickness. It's just a phenomenon that happens normally, but it's not pleasant.
So there's no treatment to take for it to prevent that happening?
So we'll move on to that in a bit, but yes, potentially there is.
Okay.
So sometimes people faint during the acclimatisation process. So sometimes it's to do with your blood pressure can decrease a little bit at altitude. And so often it's on the first day of being at a new altitude, and it's often after eating that you can have a fainting episode. But again, it's not dangerous apart from if you hurt yourself when you fall over. But it's not a marker for developing altitude sickness.
Why after eating? Is it because your body's digesting and it's altering the balance?
You tend to have a little drop in blood pressure after eating.
Yeah.
Your parasympathetic nervous system kicks in when you're starting to sort of digest food.
Yeah.
Also coupled with a reduction in your blood sugar as well tends to happen after eating.
Mm-hmm.
But it can cause a faint. Again, it's not serious as long as you don't hurt yourself while fainting. And it doesn't happen to
So if you're on blood pressure medication, there's no need to adjust it at all?
There's not, no. So no need to do that. It doesn't happen most of the time, but it can do. It's just one of those things. So let's think. So we've covered urination. We've covered. Sometimes because the pressure changes, any gas in the body will expand a little bit. So farting is a common thing at altitude.
It certainly is.
Yeah. A little bit more windy than usual.
That's not 6,000 metres, that's just
Upstairs.
Yeah.
So
It happens in Banbury. Yeah, it's every day.
Yeah.
So let me just check what I think. I think those are the normal things. So yeah. Oh yeah, of course it's sort of more common to become sort of dehydrated at altitude. So the air tends to be drier, and you tend to be doing walking a lot. So becoming dehydrated is a lot easier to do at altitude. So you've got to take provisions to stop yourself getting dehydrated. So moving on to altitude sickness. So altitude sickness is pretty much like having a really bad hangover. That's how it's best described. Almost always you get a headache. Not 100% of the time, but mostly. Nausea is very common. Lack of appetite, feeling dizzy, feeling lethargic, and it tends to happen any time between about 2 and 24 hours after moving to a new altitude. It usually just goes away on its own. It can be treated with paracetamol for the headache, anti-sickness tablets for the nausea. It goes on for average about 16 hours that it lasts for, but it just fades away by itself. It's not usually necessary to descend if it's simply acute medicine sickness. But if it becomes serious, then it might be. So it helps. So descending will definitely help relieve the symptoms, but it's often not necessary because it will resolve as you acclimatise. You're at high risk of developing it based on the altitude you go to and also the rate of ascending. if you're exercising at altitude as well. So the more you exert yourself, the more likely it is you'll develop acute mountain sickness. Alcohol is a big thing. So drinking alcohol on the first night of ascending puts you at much higher risk of developing acute mountain sickness. And it's easily confused with dehydration as well. So sort of making sure you're hydrated to help sort of prevent similar symptoms is a good idea.
So you said there's no need to descend unless it gets serious. How who defines that, and how is it defined when it becomes serious?
So we'll get into that.
Okay.
So it doesn't happen after 2 days after a change in altitude. So if you've been at a set altitude for 2 days, I mean, judging from your schedule, it doesn't seem like you're likely to stay at the same altitude for very long.
Only for that one rest day, I think. Yeah.
But if you've been at altitude at the same altitude for 2 days and you start developing these symptoms, it's not acute medicine sickness. It's something acute mountain sickness. It's something different.
Right. So yeah, you need to give it a day or two then to see how it settles down, if it settles down.
Yeah.
So we've got day 9 acclimatisation, day 12. So there's 2 days.
Yeah.
Day 12 is at 4-8.
But the most important thing, I suppose, is if someone is suffering from acute medicine sickness, it's not to go any higher. So that may have a real impact on your schedule, because if you're all planning on walking together and one of the group has the symptoms, then it's unwise to continue to go higher.
They've said that there's enough people to take people down, so the rest can continue with the climb.
So I've explained the symptoms. I mean, there is sort of some quite strict criteria to help sort of diagnose acute mountain sickness. And it's called a Lake Louise criteria. Lake Louise criteria, and there's criteria for the sort of more serious forms of altitude sickness as well. But if you score 4 points or more on this questionnaire, then that's the diagnostic of acute mountain sickness in the context of having recently gone up to high altitude. So that diagnoses it, and that will dictate whether you can continue ascending or not. So if you don't meet the 4 points on the criteria, then it's...
So how do we find out what those are? Will they tell them if they don't use that system?
They may do. I mean, but if they don't, then you can take a printout with you of the criteria.
Is that assessment of that or the outcome of that criteria points? Surely it would have to be done by the medical or experienced person rather than the patient, because we aren't the ones in the best position and the best mind to objectively judge it.
Sure.
You see what I mean?
I think you are, because with acute mountain sickness, your judgment isn't impaired. And the questionnaire is, I think there's 5 different symptoms. So it's headache, it's dizziness, it's nausea, it's sleeping, maybe one other, maybe tiredness. And it's about the severity of those symptoms. So is the headache constant, or is it sort of there for half the time? So I think you should be in a position to be able to judge for yourself
the real critical point comes as to how you define or how you react to that assessment. Then if you do the assessment,
that's what I was concerned.
You
delude yourself for the wrong reasons.
Yeah. I mean, it's better to have someone
go through it with
qualified
somebody,
assessment.
But even if you go through it with somebody, perhaps it's a routine we need to do each day, sort of thing, to just pair up and go through it.
Well, we can rule out other illnesses, can't we? Sometimes.
Just so you can be honest, sort of say, well, okay, you weren't like this yesterday. It's been going on for that time.
So having someone else objectively being able to
I
judge
never
that
get
is a good idea.
So,
well, as soon as you get a headache, that's it.
You're bound to get them there because you haven't had anything. Too lucky.
And so then the progression of acute mountain sickness is cerebral edema. Right. So that's when it starts getting serious. So it doesn't always progress from one to the other. Sometimes the cerebral edema, which is abbreviated to HACE, which is high altitude cerebral edema. So sometimes it comes on without any prior symptoms of mountain sickness. but the majority of the time there's a warning. And so it tends to come on after a couple of days. It's pretty rare. So for people ascending to 4,500 metres rapidly, I think the rate is around 2% of people will get HACE. For acute mountain sickness, I don't think I mentioned that I think it's about 50% of people at that altitude, at about 4,500 metres. If you go up straight away to that, about half people will get acute mountain sickness. To 5,000 metres, it goes up to about 90%. So above 5,000, almost everybody will if you go up rapidly.
What about the figures for ones who are going up at the 300 metres per day, taking the recommended rise?
Sure, I don't know, to be honest. It's definitely less.
Yeah,
definitely
It'd
less.
be a lot less.
Yeah,
You hope so.
yeah, because
You said it's 2% for
Otherwise, half of us might not be involved.
So
Yeah.
it's 2% for cerebral edema
Right,
for
okay.
someone rapidly ascending to 4,500 metres. Yeah. So the main difference in the symptoms is, so someone who has already had the symptoms to classify acute mountain sickness, if they develop either confusion or if they develop incoordination, so unable to walk in a straight line, either of those things,
Quite a bit of that this afternoon.
That's just
either of those things are
Yeah.
diagnostic of cerebral edema and require rapid sort of descent. If someone hasn't had any acute mountain sickness so far, both things need to be met. So it's confusion plus coordination problems. Yeah. So
And when we say rapid descent, how far down do you need to go for it to start to feel itself out?
so normally it's not that far. So 300 metres, 400 metres makes a massive difference.
Okay.
Yeah.
Oh,
And so,
Swiss machine did that, didn't he?
sorry,
The Swiss machine did that quite quickly.
really?
Fell off the top.
Oh yeah.
Yeah. It's really, yeah.
But yeah, so not,
Yeah,
not too
basically,
far.
if you've not had it sort of going up, I suppose, no, so
Yeah.
it's at a certain point. Yeah.
But
Okay.
you say you probably won't have access to oxygen, you won't have oxygen to a
They don't
hyperbaric
think it's very
chamber.
high, the people with
Right.
dealing, do they?
They probably should.
It's definitely
I was trying to find
It's a
the
stroll.
information on the website, but I couldn't
Yeah.
access it.
That's what they said when we had the meeting. He said it's not really high.
Yeah,
They said 7 and above was
yeah,
high.
yeah.
Right.
Yeah.
So forget your very high.
Yeah, yeah. Their main course of action is to just get you down.
Yeah, it's
Yeah.
down.
Yeah, which is absolutely the correct course of action. If the symptoms are severe, then sometimes using something called dexamethasone is a good idea, which is a steroid, and that just helps reduce any swelling on the brain, because that's what causes the symptoms. It's
Right.
increased fluid
How
in
do
the
you get that
brain.
into your body? Is that tablet or injection or what?
Tablets.
Tablets.
Yeah. Yeah, so it's
So should we take some? Get some?
I don't know how you would get some.
No.
So I don't know if you'd need to get a private
Internet.
prescription. Internet, yeah.
Yeah.
Yes.
Kevin will be able to get them for us.
Dexamethasone.
Do you make a note of
Make a note of
that?
that.
What's that?
How
The
do you spell it, Tom?
medication.
How
Dex.
does that- Dex?
D-E-X-A-M-E-T-H-O-N. Dexamethasone.
You're
Seems
right.
right- It seems right on the spell check.
Dexamethasone.
Methazone.
So-
Methazone.
Dexamethasone.
Methazone.
Methozone. Yeah.
Right. It's a steroid, you say?
Yeah. And I think it's an immediate dose of 8 milligrams and then 4 milligrams 4 times a day after that. But that's to buy you some time. So that
Yeah.
doesn't. It's not a replacement
No.
for descending.
No,
No.
sure, sure. But is it worth taking it if anybody does have
It's,
real serious.
Is it worth taking it as well as getting them down?
It's if descending isn't an option. So for any
Right.
part of the trip, if you foresee that there's not going to be a possibility of rapid descent,
Really bad weather or something.
then it's
Get really
useful to
stuck.
have it.
Yeah.
Because it buys you
Right.
sort of hours,
Okay.
so the symptoms don't get worse in that time.
Any side effects?
You can get rebound symptoms. So if you didn't descend,
Yeah.
then when the medicine starts to wear off,
Yeah.
then the swelling comes back
Okay.
just as bad as before.
Right.
So
Right,
it's
yeah.
not a good medicine to be taken sort of. It's not good to take it before you go, just in case,
sure, no,
because
okay.
then you'll go even higher,
Yeah,
and
yeah,
then
yeah,
you'll get
yeah,
the symptoms come back.
Okay, so
But
okay, so only if there's an issue to
yeah,
Yeah.
Right, well, this is important. It
before
empowers
you
us
can
to
down.
be able to speak to the, I can't his name, the police
Pretty.
guy. Yeah.
pretty.
Yeah. About what's he know about these sorts of things.
Yeah,
They
yeah.
might even have it.
Oh, they might have it, yeah.
They may do.
We've all,
I wouldn't be
we've always
surprised. Yeah.
Well, we can, yeah, I can
If
write
I was
to
them, I
him,
would,
write
but,
to him
yeah.
and,
Yeah.
Yeah.
with this information out, yeah, and sort of
Yeah.
say, do you have this in your first aid kit, whatever you got there, yeah.
Yeah.
They're familiar
Yeah.
with it.
Yeah, okay, good.
And so the other sort of main condition to worry about is pulmonary edema. So HAPE, which is high altitude pulmonary edema, which is the biggest cause of death at altitude. Compared to acute mountain sickness at 4,500 feet, half people will get acute mountain sickness, 2% will get cerebral edema, about 10% will get pulmonary edema. So it's much more common than the cerebral edema. And sometimes it coexists with acute mountain sickness, sometimes it doesn't. Sometimes it coexists with the cerebral edema, sometimes it doesn't. And it tends to have a longer onset of action, so it doesn't happen during the first couple of days of acclimatisation. It tends to happen between 2 and 4 days, so it takes a bit longer to come on. And the typical symptoms are becoming more and more short of breath and less able to do any activity. People often feel it first of all at night time, so wake up in the night struggling to breathe, and unlike the breathing at night where your breathing stops for 10 seconds and you breathe and then you can breathe normally again,
Yeah.
it doesn't go back to normal. You can't breathe, you've got to breathe really quickly to get any oxygen in because your lungs are filled up with water, so the oxygen exchange is impaired
Okay.
considerably. Sometimes you can be coughing, sometimes you can cough blood, sometimes you can feel very congested and tight in the chest. And it tends to make your heart rate go up and your
So what
breathing
causes the
rate
fluid
go
to go into the lungs then? What's the actual
So
mechanism for
The
it?
exact mechanism is thought to be the reduction in oxygen that you're breathing in
Mm.
stimulates the lungs to increase the blood pressure in the arteries
Yeah.
in the lungs to
Mhm.
try and force more blood in there, to try and absorb more oxygen.
Okay.
But in doing that, the pressure becomes too high and then fluid gets forced through the artery walls or the blood vessel walls,
Right.
and then you collect fluid in the tissue in the lungs. So then you've got normally like a tiny gap between the oxygen and the blood, and it becomes full of water, so it fills up, and then the oxygen exchange is very difficult. So yeah, me and Rich have seen this on many occasions in hospital with people who have other conditions like heart failure and
Yeah.
things.
Yeah.
But it's the same result that happens, and the treatment's the same. So it involves getting down as fast as possible, and oxygen. And
Within that condition, obviously it varies the severity of it, but would you be able to convey yourself down, or would it be?
sometimes not.
Yeah, yeah, sure.
Yeah, absolutely.
Okay, support them.
Sometimes not. So, but similarly, sort of a small amount of descending, so descending only 300 metres or so, will make a big difference. But it's something that people need to descend from. And aside from either using an oxygen chamber or inhaled oxygen, there was another medication which is helpful for pulmonary edema, and that's something called nifedipine, which is a type of medicine called a calcium channel blocker, and that just reduces the pressure of the blood
Right.
in the lungs.
Again, would that be taken when the symptoms appear, and then you just use it to prolong the time you got before you sort of come down, sort of thing, or not to prolong the time you got, but to sort of help with that situation coming down? Or?
So, yeah, so you take it as soon as you make the diagnosis,
Right, yeah.
and you take it while you're coming down.
So the same sort of use as the other one for these?
Similar,
cerebral-
yeah. I think it's a good idea to take it for another couple of days after
Okay.
descending as well.
Right.
And if I'm not, I think the dose is, I think it's 20. I think it's 10 milligrams straight away, and then it's 20 4 times a day after that.
Okay.
But yeah, that's
Yeah, that's not only to check and Dave. What was it called again? Dex?
so this is nifedipine.
Nifedipine.
Can I spell that slowly?
NIF.
N.
NIF. EDIPINE. Nifedipine.
So when you descend, and maybe a day or two later, whatever it might be, then everything sorts itself out? Or do you need to go to hospital or wherever it is?
I think you need to go to hospital.
Okay.
Yeah, I believe so.
But either case,
Yeah,
it's alright.
yeah. I mean, both are
Serious
conditions. Yeah.
Again, that would be the guys that would.
No, it's fine. It's just if we know this,
Yeah,
at
exactly.
least we can talk with some sort of
Yeah,
knowledge, can't we?
With the,
About what they would
if
do.
those serious conditions came on and you are hospitalised, obviously, again, there's going to be worse cases. What's the long-term prognosis, or what's the outcome? Do people recover to what level, or?
I think people, the majority, I think almost always fully recover.
Right.
Yeah, I think I'm not aware of any long-term complications of developing either condition.
Right.
As long as you catch it early.
As long as you catch it early. Yeah. So the
If you've
cerebral.
died already, you can't.
Yeah, that's difficult to treat.
Goes without saying.
But yeah, it's. I mean, the brain swelling can cause seizures and cause comas and things if it gets serious. So obviously that can have after effects. But if it's caught early enough, then I think you can fully recover from it quite easily.
Yeah.
But the other medication which people use is Diamox, which you've probably come across before.
Talked about, yeah.
Have you taken Diamox for Kilimanjaro?
One guy did.
Right.
On the morning before, or the day before the ascent, the summit ascent, and yeah, he was okay. But it was just Sam, wasn't it, that took it?
Right.
Anybody else
Sam
did?
took it, I think.
Yeah, I don't think anybody else did, but.
It's like cheating.
But I mean, we hear different things now. Sort of take it beforehand, half a tablet. Was it out your mate said half a tablet?
Yeah, half a tablet. Yeah.
Others say keep it in reserve, sort of thing. So I don't know what.
So it's used as both a prophylactic medication, so used a day or so before you leave, and it's used as a treatment medication as well. So I've taken it before. So I've been to Cusco in Peru, and I flew there from Lima, and that's at about 3,400 meters. And so I had acute mountain sickness for the 2 days that I was there, and felt pretty awful with it. And so when I went to climb Mount Toubkal in Morocco, I took the Diamox with me to sort of, because I knew that I suffered from acute mountain sickness. So if you've suffered from it before, it's pretty likely that you'll suffer from it again at a similar altitude. There's a genetic component as well, interestingly, so that's why Sherpas can go very high up and not suffer. So if you know any family history of altitude sickness, then there might be something in that. So I took Diamox when I went to Morocco, and didn't suffer from altitude sickness at the same altitude as before, so I mean it was helpful for me.
Do you suffer from anything else again? Does it have any side effects?
So it makes you wee more.
Right.
So the way it works is that it stimulates your kidney to release more a chemical called bicarbonate. So it makes you wee more, it makes you pass out more bicarbonate. And what that does is it makes your blood more acidic, because bicarbonate is alkali, so you're getting rid of the alkali, your blood becomes more acidic. So your body tries to correct that by getting rid of carbon dioxide, which is also acidic, and it does that by making you breathe more. So your breathing rate increases as a result of the effect that the drug has on the kidneys. And it's the rate of breathing which helps you to acclimatise. So it's sort of cheating in a way. It makes your body breathe faster, which isn't possible for you to do under conscious control. You can't just sit there and breathe and make yourself acclimatise faster. But it kind of subconsciously makes your breathing rate increase, and that allows you to acclimatise faster. And it reduces the amount of acute mountain sickness. So you're 75% less likely to get acute mountain sickness if you take Diamox prophylactically.
Okay. And how long before we go?
A day.
The day before we actually start the trek, or
It's the day before you go to altitude.
okay, so
Yeah.
So, what do you call that? They're about 4,500 metres or
So no, above
Yeah,
2,500.
2.5?
Yeah.
2.5.
yeah. So the day we start the
Essentially,
day before,
the
yeah,
day we
day we
start
drive
with-
out there.
Yeah.
So, okay.
So
And
it's during the acclimatisation
Yeah,
period
got it,
that
okay.
it's useful to take the medication, because it stimulates the
So
acclimatisation.
every day until we get to the highest point.
No, so just during the acclimatisation phase. I mean, I suppose you probably could take it again if you're ascending once again, and judging by your schedule, it looks like you might be.
Yeah. So, and how much?
So the dose is between 125 and 250 milligrams twice a day.
Right.
And then the treatment dose for people that get acute mountain sickness is 253 times a day.
So you can. So if you do get AMS, then you can still take more of it.
You can take
afterwards.
more of it, yeah. So rather than twice a day, you take it 3 times a day.
And what about taking either of the other drugs?
So,
You just keep those.
so the other ones are just for if you develop
Yeah,
a serious
yeah,
condition.
that's right.
conditions,
Yeah.
yeah.
Backup,
Yeah,
Yeah.
yeah.
You get all those dosages, Dave.
And they don't. Those other drugs, would that stop the Diamox taking, or
No.
you carry on? All three are compatible. I mean, I'm
They
thinking
are.
the worst case.
Yeah, I mean, theoretically,
Yeah.
You're not going to get all
Any-
three.
any
I need
shot
your
through
three.
to
You
the
can have them
right.
together.
I think it'd be down by now.
Actually, it's a good
Yeah.
question though. Can you get pulmonary and cerebral?
Yeah.
Yeah.
Same time? You can
Yeah,
do
Yeah,
that.
absolutely.
surely, if it's possible.
Yeah.
Somebody has, hasn't
Yeah.
they?
I mean, I suppose the only complication that I can think of is both nifedipine and Diamox both make your blood pressure go a bit lower. But it's
Yeah.
if you're at that stage of having to take that medication, that's the
Yeah.
least of your worries, I think.
Yeah, so,
Yeah.
Yeah.
But yeah, so in my opinion, it's a useful medication to
Mm.
take. I think it's especially useful if you've been to altitude before and suffered from acute mountain sickness, because if you do get that, you're not going to be able to ascend any higher until you've recovered.
Sure. Yeah.
So I think it will help. And the main thing to remember is just to make sure you drink enough to sort of counteract the
How much
diuretic
is
effect.
enough? What do you reckon?
The way to judge it is by the colour of your urine.
Yeah.
It's as simple as that. So if your urine is light, you're hydrated.
I know we used to try and pee clear, didn't we?
Yeah.
On Kilimanjaro, and that was
Sure.
about 4 litres. Just
Sure.
giving.
Yeah. So what's intake at sea level? Sort of about 3 litres per day, including food. That's about right. So yeah, increasing by about 1 litre to a litre and a half at altitude is usually necessary.
Yeah.
But yeah, it doesn't need to be water. It doesn't need to be clear, but
Sure.
light, straw coloured.
Yeah.
But yeah, and if it's dark, you're dehydrated.
Yeah.
I mean, you can cause complications by drinking too much, and you can
Yeah.
get water
It
intoxication.
takes all the
Salts and
natural
stuff,
minerals.
All the sodium, yeah, that's the
Yeah.
main problem. So that can be equally problematic if you're up a mountain. So you don't want to hydrate too much. But yeah, using the urine as a guide is the most useful thing. And yeah, you can't
Tom,
go wrong.
we've heard all this and this is really good, but it's like on the side of good news. It's not veering to good news. A guy of mine, this guy who went up to base camp over Everest, he went into a tent for a university, and he did so well at these tests that they did in there, even though he was 65, 66 at the time.
Mm.
And they told him it was because when you reach a certain age, something to do with your brain and how it's shrunk, it gave him an advantage being older because
That
of
makes
some...
sense.
Explain
Yeah.
that, because I'm banking on that now.
So as you get older, your brain does shrink slightly.
Yes.
And the main problem with cerebral edema is that the brain's filling up with water and it's trying to expand against the walls of the skull. And if there's no room for it to do that, then it expands downwards and squashes the brain against the base of the skull. And that causes the symptoms.
Yeah.
So, so there is some truth in that. I don't think it'll protect you against the pulmonary edema.
No. But it's a bit of good news.
It's a bit of good news. Yeah.
Put that down twice.
So, yeah, staying hydrated is very important. If your food's being catered for you, then I'm sure they'll be providing you with enough food.
Yeah.
But your calorie intake at altitude will need to increase. You need to eat more, especially carbohydrates to keep your energy levels up. So if you've been told to bring snacks with you, carbohydrate-heavy stuff is best. Sleeping-wise, might have problems sleeping. Probably a good idea to take earplugs and masks if you know you have problems sleeping anyway. it might be useful to have certain sedating medication, because if you can't sleep all night, that's going to put a damper on the trip. I don't know if anyone's taken sleeping medication before, but something called promethazine is an antihistamine which causes drowsiness as a side effect, and it doesn't have any impact on your ability to acclimatise or anything like that.
Okay.
But it can help with sleep if someone's having real problems sleeping.
Is that pretty instant in its effect, or do you have to take that?
Fairly quick, within sort of 45 minutes or so.
Okay, right.
So you spell that? B-R-O.
Pro METH IZINE.
Waking up, is that okay with us?
Depends how late you take
go on.
it. Yeah.
I really wanted to do the next bit.
Yeah, if you take it late at night, you can feel groggy in the morning. So
Right.
that's the problem. I think I would leave it, and if someone has a really awful night one
See how you
night,
go, yeah.
might want to take it sort of early evening.
Is that a
the next
prescription
day.
job, or can we buy it?
You can
off
buy
the
that
shelf?
over the counter.
Okay.
Yeah,
We'll have to get some of that.
yeah.
Right, so yeah, stuff enough to work.
But I would avoid other forms of sleeping tablets.
Mhm.
So
That's the one you recommend.
yeah, other forms can sort
And-
of reduce your respiratory rate.
Are they tablets which are one you have, or what's the milligram rate of them?
So between 25 and 50 milligrams for sleeping.
Right.
Yeah. If you haven't had it before, then 25 to start off with.
Yeah.
And then if you need it again on another night and the 25 didn't do anything, then you can take 50 as a maximum.
Yeah, because no sleep, your body's wearing out. It needs
Yeah.
less rest. It's
Yeah.
building up. And
Absolutely.
We'll have time during the day to rest, wouldn't
Well, it'll be lunchtime, lunchtime stops and stuff, yeah.
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 So I'm sure you all know about, like, I mean, you'll have all the right kit and stuff to stay warm and things.
yeah,
Um,
that, yeah.
Snow blindness can affect your
Oh,
eyes.
I'm told about that,
If
yeah,
you
yeah.
don't get snow blindness, that's going to ruin your trip.
No.
So proper sunglasses,
Yeah.
preferably with sort of side
Sideburns,
bits
yeah.
as well.
Yeah, we were told that.
Yeah. You all were kind of shaking your heads when I mentioned alcohol, which suggests that
No,
you're
we're having it
not really-
tonight, so that we get it.
The last
Other
time,
way.
isn't it? The last supper tonight.
Yeah.
Yeah, so the fact that they were staying, so on Killy, we were camping,
When you're
so there was
going
no
down,
real
you
provision for getting alcohol anywhere on the way up. In
Yeah.
fact, we're staying in tea houses this time, there is provision for buying alcohol.
Yeah.
Whether we
We're not going to do that.
No, no, just
So,
well,
The
It's,
guy who we had that training day with,
yeah, Ron.
he said he doesn't drink from the day he leaves the UK
Yeah,
yeah.
that's right.
until he's
Yeah.
on the way back.
Yeah.
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 And
Then
that's
he
He's
was
done
probably
Everest 3 times.
Yeah,
and
that's
he knows his
quite
stuff.
experience.
Yeah.
the most conservative, sensible option.
Yeah.
But
Yeah.
I
He
would,
said there was all sorts of reasons. One, there's less chance of becoming ill
yeah.
because not knowing where the beer might come from or any of the other bits. and
Yeah.
pieces.
He was as depressing as you, Tom. To talk to. I'll give you his address.
Yeah, so save all the alcohol for the
Yeah.
trips and
Yeah.
Once we've hit the peak and you're going down,
I mean, it's less problematic on the way
Yeah.
down. Yeah, absolutely.
to the right.
yeah, exactly.
The best beer I've ever had was coming off of Kilimanjaro. wasn't it?
Yeah.
place.
But I ran down,
We
I-
drank
I
about
was
a beer,
really
didn't we?
I had 6 pints before the rest got down.
Yeah.
That was really nice.
Yeah, yeah.
Um,
What about any other preparation we can make for it, sort of in terms of health and in terms of fitness? What do you recommend? I mean, we've just been out doing this high intensity stuff today, which it all helps, but no general preparations. For going
So,
out
I mean, fitness doesn't have any bearing on whether you develop altitude sickness or not.
there?
But obviously, if you're fitter, then you'll be able to do more when you're there, and so the amount that you can do is less. If you won't have to stress yourself so much, which then will make it less likely you get acute mountain sickness. In terms of other preparation, I mean, you can't really prepare for getting mountain sickness.
No, sure.
So sometimes people, I mean, you're not out there for that long, you're over 3 weeks. Sometimes people intentionally do put on a little bit of weight before going out to altitude, because naturally people do tend to lose weight at altitude. Because your metabolic rate increases so much.
I've been doing that for the last 10 years.
Good.
How far are you walking each day? Do you know?
It's
5 or
about
6 clicks.
no, it's hours, I think, 5 or 6 hours it says.
Yeah,
So I
but
guess,
distance is
because I've heard one of you say this before, I don't know if it might have been you at the wedding Adrian or you said, where if you can't walk 5 or 6 hours at sea level, you're going to struggle at altitude, but being able to do it at sea level hasn't acclimatised you.
No, sure.
No, it's a different equation altogether.
But I suppose it sort of basically makes sense if you can't do it.
Yeah,
No,
that's
no,
right.
yeah,
That's the thing. So saying 6 hours walk, 7 hours walk, 5-6 hours, then going higher, 4 hours walk, 4.5 hours. Yeah, so
10 hours for
But the actual distance is not
minute.
massive.
It's
It's
like
like
10
5-6 miles.
Yeah.
Obviously,
Yeah.
you've got altitude as well.
I think the whole thing's about 120
Obviously, we're going to go
miles, isn't it?
slower because
Yeah.
of the altitude, but
Yeah.
it's not massive distances.
No.
No, but
a
you,
week's
that's
walk.
a good job.
So yeah. So 120
Yes.
miles, I think, is over. We started checking 5. Yeah, what?
Well, there.
That's
So-
height.
Well, you've got to get from there to there.
Yeah, it didn't say how far that is.
Probably
I think it was no more than 8 miles a day or something.
Yeah,
like
no,
No, it's
exactly.
not
Yeah.
controversial.
So it's, I mean, higher
Would
you are,
you
it's about a mile
suggest-
an hour, isn't it? Something
Would
like
you
that.
suggest at the end of the day we ran up 300 metres and came back down again? Ran up Redbrook and come down again, no?
No.
You can if you want to.
Benefit you.
Yeah, you
Take
try
a
that.
skipping rope.
I don't think that would help either.
No.
Unfortunately not.
Because the guy who did the record of Kilimanjaro, he spent a week acclimatising at the top, didn't he?
Right, okay.
And
Yeah.
And
running
came
around
down
and
and then ran up
skipping.
it.
Yeah. Yeah,
We're not going to do that sort
No.
of thing.
Correct. We're not.
no, I suppose that's building up his red blood cells.
Yeah.
So that's what that's doing, sort of different form of acclimatisation.
Yeah.
Putting yourself into stress at
Is there any
altitude.
diet, as in red meat or something, that'll help before we go?
I mean, if you're not anemic at the moment, then there's no reason to
No.
increase your red meat intake. But if you are anemic, then it will help. Yeah. I mean, that's a good question. So, what medical conditions does anybody have that you want to disclose?
Yeah.
Anemic.
So,
Oh no, I'm fine.
good.
Yeah, so,
Someone mentioned blood pressure pills.
yeah, so
Yeah.
just hypertension.
Yeah, as long as it's well controlled
Yeah.
at sea level,
Yeah.
just continue on exactly the same
Mm.
regime of medication and just make sure you bring your medication with you.
Yeah.
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 It shouldn't make a major difference.
Yeah.
It shouldn't affect your chance of developing mountain sickness.
Awesome.
Outside of mountain sickness, are there any other things like, I don't know, if you've got a bit of rheumatism in your hand or
Mm.
something like that, will altitude worsen it or have no effect on it?
Cold.
I think the cold,
The cold,
yeah, the
yeah.
cold, yes. I think the altitude in itself, no.
No.
Yeah, I think so. Anyone suffer from migraines? No,
Luckily not.
good.
No, leaving all that behind.
Good. No one's had surgery on their neck arteries.
I think you know.
You'd probably know about that.
Yeah, I think we
Yeah.
do,
Good. That's and no one's got epilepsy. No.
I think, does Frenchie have asthma?
Oh, he has something, doesn't he? He
Just
had a.
for the camera.
No, he had something else condition, didn't
Yeah, but I think he has.
Yeah, he's got a
But so if he
hypothyroidism.
does have,
If you have asthma, going up at altitude is much better because there's less pollutants.
That's
For me,
absolutely right.
when I go skiing,
Hmm.
I used to never take my bluey with me when I went skiing, but if everywhere else you went.
He didn't
Yeah.
have some kidney issue.
Yeah.
Some bad days off work for 3 months.
Yeah, they don't,
He knows.
Yeah.
That it's
don't
a
have
problem.
them in diesel vehicles.
Well, I guess-
I
guess-
Gasoline,
yeah,
just
that's
do they?
Not
So
so many.
so Mark, who's not here today, if he's got, or any of the other two that got questions, can I contact you if they get
Yeah,
anything
absolutely.
specifically?
That's
So,
fine.
okay.
Yeah. So asthma is usually better at altitude,
Right,
but it's
okay.
still important to have your pumps with you just in
Yeah.
case.
Mm.
Because sometimes people get exercise or cold-induced wheezing, so
Yeah.
so just
Yeah,
having
yeah,
something
yeah,
to
yeah.
relieve
Yeah.
it is important. But yeah, generally speaking, it gets better.
Yeah.
But if your friend has COPD, which is sort of smoking-induced lung problems, then then that's something a bit different.
Yeah.
Okay. Fine.
So you mentioned about red blood cells. I mean that link, that YouTube link you sent Richard about
Rugby.
Richard.
I want to say Pry, but it's not.
No, it's
The Welsh rugby.
yeah.
Yeah.
That was quite interesting. That sort of thing. So that was all about obviously the blood thickening at altitude and everything. So I guess what is there any likelihood of that now? So what we'll be doing, and was that this was where he was trying to do it without oxygen, wasn't he? And, without Zebrich, I know. So
Okay.
He spent a long time acclimatising.
Yeah.
And he was symptomatic. and his hematocrit was too high, and they were worried about
Oh,
basically
right.
a stroke.
Okay.
Tracing
Okay.
symptom down. I guess ultimately it came
Part.
down to he
It's a
had
part.
that's it.
Yeah.
He had symptoms of acute mountain sickness. They did a test, and one of those involved his blood was too sticky, and that's why they wanted him to go down. But I suppose it was he had symptoms,
Right.
and someone told him
Sure.
he needed to go down.
Right.
Yeah.
So it's a specific situation, you think, then, in that case?
I guess maybe it's the more useful example is maybe that idea of he's a super fit,
Yeah.
elite sort of level athlete,
Yeah.
and for him the problem was a bit different, but he still got acute mountain
Right.
sickness.
Right.
It might have been due to a slightly different thing.
Yeah.
Actually, his blood was a bit too good at carrying
Yeah.
oxygen. He had too many red blood cells.
Yeah.
But ultimately, he had altitude sickness and had to go down.
Okay. So
But he
that won't
wasn't-
affect here versus Uncle
No, we won't be near that.
No, for the duration that you're there, it's not going to
Yeah, sure,
it's not going to cause any
Yeah.
problems.
But it was interesting. I think the point you were making at the time that super fit people like that can still have problems.
Yeah.
Absolutely.
Yeah.
Yeah.
So,
And so when I went up Kilimanjaro, we were in sort of groups of.
Did you do it with
3.
Richard? Because he was really ill.
Yeah, I was really.
No.
No, he didn't.
No, but that was we stayed at about 3,300 meters at the sort of the base camp. So it was a 3-day thing, up to base camp, up to the peak and down again, then back to the sort of main town.
Yeah.
And so we slept at about So it's not that high. So it's only 4,150 or
What's the
something
next
like that.
mountain?
Toubkal.
All right.
So it's the highest in North
North
Africa.
Africa.
So it's in Morocco. And so we stayed at about 3,300, and then went to the summit that day. And there was one guy in our group who had a bit of a headache and a little bit of feeling sick that night, but not really to the extent where he'd made a big deal out of it. And then a few hundred metres from the summit, he started saying, "Look, I'm not feeling so good." And the guide we were with at the time wanted everyone to summit, wanted us to go up. So the rest of the group were quite happy to sort of take a step back and let the group leader make that decision. And then the guy who had the symptoms was the last person that was going to step in and say, like, I don't want to carry on.
It's difficult. Yeah.
So he didn't want to stop anyone else summiting. He didn't want to sit at the side of the path and wait for us to come back down again. And so we pushed on to the summit and spent about half an hour there, and that's about 4,150-ish metres. And then his symptoms really started to get bad as we were descending back down to the base camp, and his headache got worse. He totally lost coordination, so he was having to be supported all the way down. So he had to have one person with him at all times because he was so unsteady. He was having to walk with 2 walking poles. He was not confused, but he was probably sort of head down, not talking to anybody, just concentrating on putting one foot in front of the other. And additionally, we ran out of water, so it was a really hot day. We didn't have enough water. We gave him the water sort of preferentially, but even with that, we all ran out a good few hours before we got back down. And then it went dark, and so half of us had head torches, the other half didn't, and it got cold. And so for the last couple of hours coming down was such a slog and so kind of arduous. And
Did you
having
do
to
this
go at
yourself
speed.
or with a company?
So this was with a company. So this
An
was a group of
experience.
doctors.
Sure,
This
yeah.
was a group of doctors doing an altitude medicine course
Oh,
in
right.
Morocco, including
Wow.
doing
Well,
the
this is-
summiting.
I wanted to do it this way, so you'd learn.
Yeah.
Maybe. But yeah, I mean, in retrospect, it was a bad decision to summit.
It's wrong.
Yeah.
But
yeah,
you-
sounds like,
At the circumstances at the time, everyone was like, "Come on, let's do it. Let's
Yeah.
let's
But
get to the top."
did the group leader make that decision? That was a wrong call.
Absolutely,
That is pathetic.
absolutely.
Well, in hindsight,
With hindsight,
hindsight is a wonderful thing.
Yeah,
But these guys must have come across that lots of times.
you'd think so. But obviously, he didn't have symptoms of cerebral edema at the time when we made the decision what to do. He did have symptoms. He did have symptoms of acute mountain sickness, and even that 100-metre difference. So going up to 300 metres.
Did you make a full recovery? Please tell me.
Oh yeah, he did. Yeah, so within a few hours of being back at base camp, he was
Yeah, it's
absolutely
amazing how
fine.
quickly you recover.
Yeah,
Yeah.
It really is.
but But yeah,
But it's no fun at the time. So
Yeah, on our trip on Killy, one guy, I was totally oblivious to it because
because you would be.
I was living my own dream. He said
No
that
sense,
it
no
was.
feeling?
We went up Mount Maru first,
Mm.
and he said it was like he would have not got out of bed. It was the worst hangover he'd ever had.
That was Richard, was it?
No, why didn't go with you lot?
No.
Oh,
So I was going to say,
Yeah,
on our trip, the first person to suffer
Youngest,
was the
fittest.
youngest and the fittest.
Yeah.
He was in the Navy at the time, and but yeah, he was. Yeah, but he recovered from it. He just had a bad headache one lunchtime, and we got to about 4,500. And but yeah, because we were coming down again after that, he was okay. He didn't suffer again after that. I see something to you, didn't you, Colin? It was you
Yep.
and Richard and
Bill.
Bill. Yeah.
He was sick on the way up, Richard.
Was he?
Yeah.
What, on that last morning?
Yeah.
Like you
Alright.
actually vomited.
Were you symptomatic at Killy? Colin? Were you symptomatic on Killy at the top? You were alright?
I couldn't breathe.
Yeah. That's right. That's right.
There's literally no oxygen.
Yeah.
At Stella Point, I went down 20 metres to help someone and pulled them back up, and then something hit me, and I thought, I'm getting up the top by myself now.
Yeah.
Me for myself.
Mm.
And I had my little thing of whiskey for the top and forgot about that.
Probably very
that was
sensible
serious,
too as well, yeah.
Because you know each other, you should be all right at this because you might behave differently if you're affected.
Yeah,
And
notice.
so
Yeah.
So I had cerebral edema on Killy,
Okay.
and was really ill. Didn't really understand it until afterwards, I don't think. And it was both, our guide at the same time, sort of put me at quite a lot of risk because I was clearly unwell at the base camp before you climbed the Bankura wall or something like that. I don't know what that was called. So headache, vomiting before we made that summit stop. And then during the ascent overnight was completely ataxic, hallucinating, totally disastrous, can't talk. And I think full recovery, maybe some slight residual brain damage. But
not me.
I think we were again in a group. It was with a company, and some people had oxygen and was even carried to the top with oxygen. It all seemed a bit wrong in retrospect.
What sort of group was that, Richard?
That was a group we were volunteers at the time, so we didn't know each other.
Okay.
But I think anyone maybe who, now that you know this and you know each other, if someone is suddenly, hang on, they've gone quiet, they're lagging behind, and they never lag behind, or they never switch up, but now he's quiet.
Well, I think it's interesting because I think we do that generally when we're out on training walks or just weekends together. I think
If
everybody's
I'm
out for each
quiet
other.
or off my food, it's
something's not right.
We just keep quiet and let them be like that.
phone the private ambulance.
And if you want to check if someone's so ataxic is when basically your brain's not working, you can't coordinate. It's the heel-toe walking. It's the sobriety test of the old American police. This, and can you walk heel-to-toe in a straight line? And if you could at 4,000 metres, which you can't at 5, it's not good. It's not
We'll
good.
try that one tonight, boys. Right?
Yeah, I think as well as a team, we'll ask if they're, as a matter of course,
Yeah.
every evening,
I mean,
are you okay? You
sure.
feeling anything?
But it's probably a good idea to have. It's a good idea to have like a buddy system to
Oh, yeah.
check for frost
Yeah.
nip. For frost nip, that's very useful as well.
Or frosting it.
Yeah.
That's a new one.
Yeah. So frost nip.
So-
you've got to be. So frost nip is when your skin freezes.
Yeah.
So you've got to have a very good friend to check all your extremities.
That's right.
No,
What's that be that all night for?
The thing about frost nip is you can't feel it, so it's numb. So your skin goes numb. So often you don't realise you have it. So if you've got a numb chin or a numb tip of your nose, you won't realise.
Extremity, isn't it?
So that's why you've got to have like a buddy system
Oh,
to check
just
each
poke
other.
you in the nose.
Just poke you in the
If you
nose.
feel it, good. If you don't feel it,
But it kind of looks like wax, so it kind of looks like someone sort of dripped wax on the skin. So it's got that kind of shiny, waxy kind of
Put that down,
appearance.
Dave. Wasn't it?
And then it's numb and it's cold as well, and it just needs re-warming. So you just need to put something warm against the skin.
Don't go there.
no.
We're not that friendly, are we?
So, do you want to share?
Straight away,
No, we're right.
Chilly.
Rich, when you did yours, did you put your trust, because you were on that volunteer scheme, I
It's
remember
trust.
Trust.
Oh,
You've done that one. You put the trust in the group or the leaders who took you. You didn't previously think you were perhaps going to do that, and you hadn't researched it. Is
That's
that what
right,
it was?
yeah, we did it. We were in Tanzania.
You hadn't planned to do it, really.
No, we
No.
hadn't
Okay.
gone prepared and were woefully underprepared. And I
Yeah,
think
yeah.
we probably had hypothermia as much as anything else, but
Right.
a few of us were really unwell and shouldn't have been allowed to go up. But we did, so it should
So
be a different
you
thing.
just went and chose a local company there and the thought of
Yeah.
killing and yeah.
Yeah.
Just talk about cold things and everything. Raynaud's syndrome, so I have Raynaud's. Is there anything to treat it with, or I've never been able to find anything yet? And is there any other precautions I should take? Going even higher now than I was on killing.
Sure.
Older.
I think the main thing is just to make sure you've got bloody good gloves.
Right.
I don't
Should
think,
find some, but yeah. yeah.
but altitude shouldn't make a difference.
Right.
The cold obviously will,
Yeah.
and one drug that you use for Raynaud's is nifedipine, which is the same thing you use to treat pulmonary edema at
Okay.
altitude.
Right.
So I don't know if you've ever had that
No.
for Raynaud's,
No. So,
but it's one of the licensed treatments.
okay.
Um,
You say that's not over the counter, is that prescription?
no prescription. only.
Okay, but a GP will be able to prescribe that. Okay, we get a new GP. We just went down Salisbury, so I haven't signed on yet. I think.
Right.
Find one, so. Okay.
Actually, to talk about other things. I mean,
Yeah, thank you.
did you say you've been to Himalayas?
No,
you haven't.
no.
All right, okay. So
Are you free in October? She sounded so you might be using first to have it.
yeah. I mean, it was just I was more that when I went to see the nurse do injections and stuff like that. But one thing that she was when she looked it up and she started looking at different things and she was a bit unsure, and then she decided I think I needed was rabies. I don't know whether it just was one.
I think
I don't care if I need that. I ain't paying for it.
No, the reason why she'll have recommended that is probably because she'll have just looked at what country you're going to.
Yeah.
So she'll have highlighted Nepal and it will have said there is rabies in Nepal.
She said
Yeah.
there were
Consider-
cases
yeah,
of
consider
people
this as an
being
option.
bitten by dogs tourism,
Yeah.
because that's
Yeah.
what she was going on.
Yeah, so in where he's flying into.
Come and do.
Right, okay. So
And we're higher up, so we don't need malaria either.
No.
So yeah, so I guess there's no.
I mean, rabies is a
Dogs aren't any
possible.
more.
I'm sure there's rabies in Nepal, but
Yeah.
but it's very low risk.
So
if you
dogs
can-
aren't any more vicious in Nepal than they are anywhere else.
So Colin, no biting, okay.
Yeah.
I've been
Yeah,
tested,
you
haven't
can rub on the case,
Been
no
tested.
biting.
Just like a buddy system and take revolvers.
I? Not a sniffing can go on, but no biting.
So what jobs did you have for Nepal?
Sorry.
What injections would you have for Nepal?
I don't
They're
know
all
off the top of my
on
head.
the
Yes.
Yeah.
We've looked into that.
Hepatitis A.
Hepatitis.
Yeah, I've had all the bits because I had to
Yeah.
have them from India. I'm off to China in 2 weeks, so I'm literally up to date with everything.
He's
I
doing a
can
world
think
tour in
of,
a year.
to make sure
Asian.
Yeah.
Bits of it,
but it was the rabies bit that got me really, which
Yeah,
is sort of
strange
simple.
one.
Yeah.
Yeah.
So just the frostbite, really. Just the prevention of that is just keep because you can't when I'm cold, usually I just say exercise more, but we won't be able to do that because there's
No.
oxygen there.
So-
Waiting maybe time if we're crossing the crevasse and stuff.
Yeah. So frostbite is serious, and frostbite needs evacuation. Frost nip is a precursor to that. So if you get frost nip, that's why it's important to have checking each other regularly, because if frost nip turns into frostbite, it's the end of the trip for you basically.
So how did you say checking? You said you got shiny bits on
Yeah.
your nose, but you were saying getting
Sense.
someone else to
Yeah, so
Sense.
frost nip
Yeah.
is frozen skin.
yeah. So,
So-
you just get. If I'm with Colin, I just poke him in the nose or something like that.
Well, you can do it yourself, can't you? You can feel whether you can feel your nose or not.
Yeah, so the checking.
Yeah.
But the
right.
checking
Oh,
is the checking is the visual, so it's
Ah,
looking
right,
to
right.
see if there's
Yeah,
if there's bits of skin that look like they're
But
affected.
you're not aware of it yourself, as I was saying.
Yeah,
so
no,
because
you
it
do a
goes
routine
numb.
check, whatever. We can all go around and do that. And thanks, that's
Yeah.
good.
Yeah.
But then if it's numb, it's cold, and if it's
Yeah.
waxy looking, then that's frost nip. And you should be able to thaw it out within half an hour or so. So thaw it out within half an hour. by just putting something warm against it, not by rubbing it, because if you rub it, you'll
It
damage
might come
the.
off.
It might come off,
She
exactly.
Steady, Colin.
Another one, Tom,
Yeah,
to do
that's
with
it.
illness you can get. We've been advised. I think they're going to be boiling our water and tablets in it. What's the sensible thing from you on that? As in drinking water, we mean drink 4 litres a day.
Yeah.
Because getting sick's not a good option, is it really? As in bugs.
No,
Yeah.
no, absolutely not. So iodine tablets
Right.
tend to be what people use.
Okay.
Yeah, I mean, there's all these fancy things like the magic straws that you can stick in stuff, and it filters all the bugs
Or
out.
the ultraviolet things.
Yeah.
Iodine.
The ultraviolet's not as effective, I don't think, as iodine.
Right.
But iodine's people don't like because it makes the water taste funny.
Oh, it doesn't matter, does it?
You get
It's
used
not
to
about
it.
enjoying yourself. And what's the dilution or what?
I don't know off the top of my
Okay,
head.
we can look at that, yeah. We can have some of that tonight, actually. We won't do beers, we'll do iodine, no?
Wonderful.
Water passed by the management.
Yeah, well, any more questions? Because that's been very, very useful. We've got it on record.
I'll email you the drugs and doses and stuff.
That's brilliant. Yeah.
Yeah, just to make sure I've got them correct.